والزميل العزيز بسم الله الرحمن الرحيم. وانا بدايه برضه بشكر الدكتور عادل على دعوتنا هذا الاجتماع مع العرب مع الريجن كله. سعيد جدا بنقدم الاستاذ الدكتور إناس شلتوت عشان تتكلم لنا على موضوع من الموضوعات الهامه جدا، خاصه وان البوبوليشنز كلها في العالم are coming to be old. الاولد ايج فينومينا اصبحت ظاهره، واعتقد بالتحسن في مصر الناحيه الصحيه والعلميه والثقافيه والاجتماعيه، اعتقد ان عدد البوبوليشنز اللي هم هيبقوا الدر في مصر يستحق ان يكون يحتاج الى محاضرات ويحتاج الى تثقيف، خاصه وان دايابيتس زي ما بنقول في بعض التعريفات بيقال عنه the disease of the elderly. فهنستمع من الاستاذ الدكتور إناس شلتوت على الكثير ان شاء الله. اتفضل يا استاذ دكتور إناس.
بسم الله الرحمن الرحيم. My dear distinguished professors and my dear colleagues, Mr. Chairman, I'm going to talk about diabetes mellitus in geriatric times. Life expectancy has been increasing. Advances in medical care and improved social conditions led to increased life expectancy. Life expectancy has been rising since the 18th century. And in Egypt, for example, during 2000, the age demographic was like a pyramid, and expected to be in 2050, we're going to have the percentage of persons above the age of 80 and 85 are going to be markedly increased. There are some chronic health issues in older adults, like arthritis, diabetes, hypertension, chronic sinusitis, visual impairment, osteoporosis, hearing, varicose veins, emphysema, deformity, dementia, and 34% of older adults are affected with more than one condition. Those are called giants of geriatrics. Some age-related health problems like dementia, mobility impairment, falls and incontinence, and some iatrogenic disorders, possibly due to polypharmacy and health system problems. Some functional limitations may happen after the age of 85, like walking impairment, getting outside difficulty, passing difficulty, transferring, dressing, using toilet, eating, preparing meals, managing money, using the phone, and some light household work. Does the epidemic of diabetes involve older individuals or not? Yes, by the year 2050, there is going to be 336 increase in diabetic patients above the age of 75. The prevalence of diabetes, according to the National Health and Nutrition Examination Survey, above the age of 25 was about 7 to 8%, while above the age of 75 was 17 to 21%. Diabetes in geriatric times is somewhat different as regards goals of therapy, choice of drugs, change in metabolism, and danger of hypoglycemia. Most studies shows rise in blood glucose, especially the postprandial blood glucose, directly correlating with age. There is increase in fasting blood glucose 1 to 2 milligram per decade, and postprandial blood glucose increases up to 15 milligram per decade. These changes are due to impaired insulin release and delayed suppression of hepatic glucose output. Diabetes is a risk factor for dementia. It is doubling the percentage of dementia, falls, hip fracture, immobility, and some disability. In an Australian study, the Fremantle study, for those persons above the age of 70, dementia was found to be increased above the age of 80 to 27% of diabetic persons, while in normal Australian persons above the age of 80, it was 8 to 11%, while depression was increased 7 times in those patients or those persons above the age of 70 in diabetic persons versus non-diabetic persons. Those are some complications of diabetes in older patients, macrovascular complications and microvascular complications. The coronary artery disease was doubled, stroke is doubled, amputation 10 times increased in older patients. The microvascular blindness increased, renal impairment is doubled, and neuropathy is increased, but the percentage is not known because of increased incidence of neuropathy by age. These are some challenges in the management of type 2 diabetes in the elderly. Acute metabolic complications like diabetic ketoacidosis, it is rare, but the features and management are the same, and there is higher mortality due to associated cardiovascular disease. Hyperosmolar non-ketotic coma, 50% happen in newly diagnosed diabetics, and it always occurs in older individuals due to impaired maintenance of serum osmolarity, decreased thirst perception, and decreased access to water. Acute infection is a frequent precipitating factor, usually pneumonia, and it is difficult to manage due to difficulty in rapid fluid replacement in those patients due to cardiovascular disease. Is there a risk of hypoglycemia or not? There is increased risk of hypoglycemia, and it may lead to impaired cognition. In older patients, we find more neuroglycopenic manifestations of hypoglycemia like dizziness, weakness, delirium, and confusion compared to adrenergic manifestations which are usually happening in those diabetic patients with hypos in younger individuals. Hypoglycemia is a major challenge either due to patient risk factors like chronic liver or kidney disease or cardiovascular disease, or lifestyle problem like poor nutrition or fasting in older individuals, and of course drug risk factors like hypoglycemia produced by insulin or sulfonylurea. 17% of hospital admission in older diabetic patients is due to hypoglycemia or severe hypoglycemia. What about chronic complications? Neuropathy is the most common symptomatic chronic complication in older diabetic patients, and the clinical diagnosis is often difficult due to already present neuropathy, either autonomic neuropathy or peripheral neuropathy related to age. Bladder dysfunction is also very common, and it has to be differentiated from senile enlargement of the prostate. The clinical presentation of diabetes in geriatrics, it may be confounding and routine screening is recommended, or it may be totally asymptomatic. Presentation may be with urinary incontinence, monoocular neuropathy, onset of sexual dysfunction, minor and difficult to control infection, so we should suspect early. Geriatric diabetes, some unique syndromes of diabetes in the geriatric age, like diabetic neuropathic cachexia with weight loss, depression, painful peripheral neuropathy, and this condition resolved without no specific treatment, diabetic amyotrophy, malignant otitis externa, pyelonephritis, intradermal bully of the feet, periarthritis, and increased risk of accidental hypothermia, nephropathy due to gradual decline in the renal functions, Coronary heart disease, one of the major causes of death in geriatric diabetic patients. Infectious complications, high risk of tuberculosis, and the presentation is usually atypical, like lower lobe tuberculosis and fulminant tuberculous pneumonia, frequent UTI, necrotizing fasciitis, candidiasis, malignant external otitis media. What about the management in older diabetic patients? The clinical standards, according to the American Diabetes Association, age per se should not be an excuse for suboptimal control of diabetes, but the goals should be individualized according to the age, the lifespan, and the comorbidity. And according to the latest recommendations, hemoglobin A1C may be left up to 8%, a less tight control of hemoglobin A1C. Diet, it's difficult usually to adhere to strict diet in older diabetic patients, and no strict diet is needed. Vitamins and minerals should be supplied if the caloric intake is less than 1,000 kilocalories per day. What about exercise? There are benefits and there are risks of sudden cardiac death, foot and joint injury, and hypoglycemia. Oral hypoglycemic agents like sulfonylurea, there is a clear and present danger. 20% of sulfonylurea patients develop hypoglycemia. Biguanides, they shouldn't be used in patients with renal insufficiency or hepatic insufficiency, otherwise they are safe. Alpha-glucosidase inhibitors, they are safe but may cause severe GIT disturbance. Thiazolidinediones, they are safe in older individuals, but side effects and complications are taken into consideration. Incretin-based therapy, GPP4 inhibitors, they are safe in older diabetic individuals due to very low risk of hypoglycemia, and GLP-1 analogs, they are also safe in diabetic older patients. What about insulin? There are some concern about possible medication error, like visual impairment, impaired mental disability, and limited access to injection site. And insulin analog look to be more safe in those older diabetic patients. And Mr. Andrew Mandel, he's called now Mr. Diabetes because he has been walking thousands of miles around different US states, and his neuropathy has been disappearing after taking his long journey. Thank you.